introduction. قبل ما ابتدي الحقيقة I wish to thank Professor Dr. Azza Abdelgawad for giving me the opportunity to share in this great scientific meeting, وبشكر all the organizing committee. الحقيقة today I'll speak about metabolic emergencies. My presentation flow charts will be background on metabolic emergencies. Then I'll pass into inborn errors of metabolism with acute life-threatening illness. And then I'll focus on metabolic crisis causes, clinical presentation, and initial evaluation. Then I'll give an example of emergency management of inborn errors of metabolism for a urea cycle disorder. Inborn errors of metabolism can present as an acute metabolic emergencies resulting in significant morbidity, progressive neurological injury, and death. The classic presentation of inborn errors of metabolism that produce metabolic emergencies is for initial acute presentation in infancy, often in neonatal period. This is usually attributed to patients with severe enzyme deficiency, those who present initially in the neonatal period, followed by recurrent episodes of metabolic decompensation, usually with infection. Some patients with residual enzyme activity may present first in childhood or even adulthood. Although those patients are lucky that they do have some residual enzyme activity, those patients can present with severe, catastrophic, acute metabolic crisis, their first presentation, which could be fatal. So this is very important to give a high index of suspicion of such patients. For example, if we find a patient late after not presented initially in neonatal period, and I took history from the mother that some patients, they do have poor school performance, they do have aversion to eating protein, they do have recurrent intermittent acute attacks of decompensation related to infection. I have to think about inborn errors of metabolism, and very important, I have to do investigations during the attack because those patients in between, they are normal. So I'll miss the diagnosis of those patients. Inborn errors of metabolism causing acute metabolic decompensation can be grouped into disorders of intermediary metabolism, disorders of neurotransmitter metabolism, as well as disorders of complex molecule. The majority of disorders of intermediary metabolism, that is to say classic inborn errors of metabolism, can present with acute life-threatening presentations. For example, organic acidemias like methylmalonic, propionic, isovaleric acidemias. For urea cycle disorders such as carbamyl phosphate synthase 1 deficiency, OTC deficiency, as well as fatty acid oxidation disorder and maple syrup urine disease. Metabolic crises occur when there is a build-up of toxic metabolite, usually for the intoxication disorder. But though there will be a gap or a period until there is accumulation of toxic metabolite, but this is not generally the rule, because sometimes the passage of the baby through the birth canal is causing catabolism for this baby and resulting in severe acute metabolic decompensation even at birth without even taking any protein intake. Triggers include the factors that cause increased catabolism, for example, acute infection, surgery, trauma, or even the birth process, as I said. Increase the consumption of food components such as protein intake when shifting from breast milk to cow's milk. Usually, the mothers who do have patients who presented in the initial metabolic crisis, when usually we told them about how to count units to take regarding the protein intake per day. And the mothers usually they don't acquaint it as the start of period of weaning, so we can find recurrent attacks of acute metabolic decompensation for second half of the first year. Acute metabolic decompensation typically occur, as I said, after a period of apparent well-being, but this is generally not the rule. But usually I've found that any patient, any newborn who had been discharged and he was of a good birth weight and become readmitted again to the NICU without any surgical cause or without anything, and then he was found to have severe dramatic decompensation, I have to think about inborn errors of metabolism and have start a workup. The duration of symptom-free period may range from hours to months and sometimes years, as I've said. This is attributed to the residual enzyme activity. Acute metabolic decompensation requires prompt recognition and intervention to prevent mortality and longer-term morbidity. As Professor Hala said, time is very important for metabolic disorders. So when we saw those patients in emergency room till the start of treatment, this is important, crucial for their neurological outcome and for the good quality of life, because time is very important for these patients. For example, for urea cycle disorder, the time related to the number or the increase in ammonia level and the duration of a start of treatment can affect the cognition for those patients, neurocognitive outcome. When to suspect inborn errors of metabolism? Actually, there are no specific symptoms or signs that I could say, yes, it is a metabolic disorder, but there are some alerting signals which can raise a high index of suspicion, not useful in making the diagnosis, but when observed in combination, that's to say multi-system involvement without a known cause, are suggestive of diagnosis. For example, poor feeding, lethargy, vomiting, anorexia, rapid deep breathing, compensatory respiratory changes, unusual odor, convulsion, coma, hypothermia, apnea, hiccup. Neonatal crisis cannot be differentiated from sepsis. So very important, I have to run septic workup parallel with workup for inborn errors of metabolism. When it came to me negative for inborn errors of metabolism, well and good, I can treat sepsis, because sepsis can be the cause or the trigger factor for the metabolic decompensation. And I have to think about inborn errors of metabolism also with sepsis. Metabolic crisis clinical presentation, as I've said, can be related gastrointestinal problems. For example, I can find the baby who was feeding normally then started to have weak suckling, or the baby cannot have a good amount to feed because he does have lethargy, hypotonia. He's not well to take his feed. I have to think. Also, if there is nausea, vomiting. Lethargy and coma. Coma can be seen in a lot of inborn errors of metabolism. For example, aminoacidosis such as maple syrup urine disease, as also can be seen in urea cycle disorders, and also we can see cerebral edema for patients with maple syrup urine disease attributed to high leucine encephalopathy, as well as also for patients with urea cycle disorders attributed to excessive or increased ammonia beyond the normal level. Respiratory, we can see for those patients who do have, for example, a metabolic acidosis, those patients are found to be tachypnic, could be attributed to increased organic acids, and also we can find patients with urea cycle disorders having rapid deep breathing, and those patients, the increased ammonia level can cause stimulation of the respiratory center, causing hyperpnea with respiratory alkalosis. So I have to think for those patients with urea cycle disorder. Seizures. Also, for patients with seizures can be seen in the disorders of inborn errors of metabolism. For example, pyridoxine-dependent seizures. Also, seizures can be secondary to hypoglycemia. So very important, when I saw patient in emergency room, I have to start to do glucose check, random blood glucose level, because those patients could be fatal from hypoglycemia, which is easy to treat, not to be missed. Sudden infant death, although inborn errors of metabolism, there is attribution small but significant role of inborn errors of metabolism for the cause of sudden infant death. For example, fatty acid oxidation disorder, we can find patients who were diagnosed with fatty acid oxidation disorders found dead even before the result of newborn screening. This was attributed to arrhythmia. So this is the most common example when we do have history, or we took family history and we heard that there is a family history of sudden infant death. We have to think one of them is fatty acid oxidation disorders. For initial evaluation, we have to take a good history, and then we have to know consanguinity, because usually most of the inborn errors of metabolism result of consanguineous marriage. And also, if we can find maternal help, this gives a clue, for example, to long-chain fatty acid oxidation disorder to the baby. So we have screened babies of maternal help for fatty acid oxidation disorder, especially LCHAT. History of similar illness, especially in siblings, can give clue also to inborn errors of metabolism, unexplained neonatal death or sudden infant death, as I've said before. Physical examination, we have to have comprehensive and focused physical examination. This is the key to reach the diagnosis in a timely manner. General condition of the baby may raise the suspicion of inborn errors of metabolism. Sick-looking baby may suggest intoxication, especially in the presence of stigmata of encephalopathy, such as lethargy, seizure, hypotonia, and coma. Important clue I have during a physical examination: abnormal odor of the unit is a useful sign for a metabolic disorder. For example, for maple syrup urine disease, I can smell the maple odor in the cerumen as early as 12 to 24 hours in untreated patients. And also I can smell it in the urine by the 6th day of age. So this is important clue. Another example, sweaty feet for patients with isovaleric acidemia. And here, tachypnea with respiratory alkalosis in a sick neonate may suggest urea cycle disorder. Eye examination is a window for diagnosis some inborn errors of metabolism, for example, galactosemia, which can be detected as early as first day of life. Jaundice and hepatomegaly may suggest metabolic liver disease such as galactosemia and tyrosinemia. I have to do very important when I saw patients in the emergency room, I have to start basic investigations such as blood gas, plasma electrolytes, plasma glucose lactate, plasma ammonia, CBC, liver function test, bone profile, coagulation profile. Very important, I have to know anion gap, because if I find metabolic acidosis with high anion gap, I have to suggest inborn errors of metabolism. And also important, I have to do urine ketone, because if I found in a newborn ketones, it is highly suspicious that there will be an inborn errors of metabolism for this baby. Special investigation, it has to be done in a specialized, well-equipped metabolic labs who have expertise in the interpretation of the result, because those special investigations very important to confirm a diagnosis. For example, acyl carnitine profile using a tandem mass spectrometry, which can be done in dried blood spot, plasma amino acids, urine organic acids to confirm a diagnosis of organic acidemias, and urinary orotic acids, which can help to differentiate different types of urea cycle disorders. The key facts that for all adequate samples for basic as well as special metabolic investigations must be obtained to cover all differential diagnosis. This is a basis for rational therapy. Basic laboratory investigation must be available in all hospitals, offering emergency treatment for children 24 hours a day, 7 days a week, and the results should be available at latest within 30 minutes. Special metabolic investigations relevant to the diagnosis of potentially treatable metabolic disorder should be available within 24 hours, latest within 48 hours. Testing should be performed at the time of presentation. As I said, I have to know what type of tubes or what type of samples. For example, for urine organic acid, I can take samples and put it in the fridge during the acute metabolic crisis, and then I can send it to the lab next day if I faced a patient having a problem during the weekend. So very important to have the samples during in time of presentation or when symptoms are most pronounced, because laboratory values may be normal when the patient is well. Blood and urine samples in patients with persistent seizures, dystonia, or focal neurological signs should be obtained at the time of initial evaluation. When do we suspect? What will be alerting after doing all these lab tests? If I find acute metabolic acidosis with increased anion gap with massive ketosis, I have to think deeply of organic acidemias, which is the most common cause of acute metabolic acidosis with high anion gap with massive ketosis. Respiratory alkalosis with hyperammonemia and encephalopathy, those are triad to suspect a urea cycle disorder. If I found hypoglycemia in the absence of ketone, I have to think about fatty acid oxidation disorders. In case of hyperammonemia, I have to ask myself 3 questions. What are the blood gas? What is the CBC? What are the urine ketones? Primary metabolic acidosis, urine ketones present, pancytopenia present, I have to think about organic acidemias. On the other hand, if I found primary respiratory alkalosis, urine ketones absent, pancytopenia absent, I have to think about urea cycle disorders. Quickly, I'll move just the example for emergency management. Emergency management, infant and the children with critical metabolic illness require immediate management to prevent further acute deterioration and long-term sequelae. Appropriate and aggressive treatment before confirmation of diagnosis may be life-saving or prevent or reduce long-term neurological sequelae of some of these conditions. Sorry for time, I just take 2 minutes. Emergency management by two things, symptomatic as well as specific treatment. Symptomatic treatment, I have to initiate treatment as quickly as possible, no matter I don't know what the patient had. I have to start the initial treatment that doesn't require knowledge of the specific metabolic disease or disease category. In any critically ill infant, I have to start airway, breathing, and circulation must be established. I have to treat dehydration with normal bolus, but I don't use lactate ringer. And also I have to correct hypoglycemia, acidosis, and hyperammonemia for newborn. If there is ammonia more than 150 micromole per liter, I have to start management. Also hyperemesis, consider antibiotics, especially broad spectrum antibiotic. Specific therapy is usually initiated after confirmation of diagnosis. Treatment should be planned in consultation with a genetist or a specialist in metabolic disease. Here I just want to show, this is the recent suggested guidelines for diagnosis of management of urea cycle disorder. This is by Professor Happelry and colleagues' expertise in the management of urea cycle disorders. Their management based on that we have to manage acute hyperammonemia, neurological abnormalities, and impaired cognitive function are significantly correlated with the duration of hyperammonemia and encephalopathy. Treatment should be initiated as soon as a urea cycle is suspected and should proceed concurrently with the diagnostic evaluation. Hospitals should be always have available a first-line medication and consensus-based written protocol on how to proceed. First action, stop protein intake to stop more nitrogen load, start intravenous glucose with appropriate electrolyte, initiation of first-line medication, collection of plasma and urine for diagnostic purpose without postponing initial treatment, transfer a patient with hyperammonemic crisis to a center without delay. Specific treatment, the pillar is reversal of catabolus, promotion of anabolus, detoxification, and this can be achieved with high dextrose. Usually we have to cover a caloric intake nearly more than or equal 120% of expected energy requirement, and this can be achieved by IV glucose, dextrose 10%. We have to insert a central line. If I do have glucose more than 12.5%, because the peripheral line up to 12.5, I can add for requirement of calories, I can add intralipid, but I for those patients, and also I start insulin 0.05 unit per kg per hour. If the patient is hyperglycemic, I have not to decrease the glucose concentration. I have to start the insulin and then manage according to the DKA protocol with frequent monitoring of glucose level. For the specific treatments, I have to stop natural protein 24 to 48 hours. This is to avoid catabolism, more breakdown of tissue protein, and detoxification for ammonia use alternative pathway, which can be either by ammonia scavenging medications as well as hemodialysis, which can be used in case of ammonia more than 400 micromole per liter, or the patient not responsive within 3 hours. And here, this is a very nice tables for undiagnosed cases as well as diagnosed cases based on the ammonia level. And also here we can see that in patients who is confirmed to have types of urea cycle, it can be managed. We can start by intravenous sodium benzoate, which can be started initially, and if there is no response, we can handle sodium phenyl butyrate, then L-arginine, and then carbaglu. We can use these medications one followed by the second, or we can use them in parallel in case of severe metabolic crisis. In conclusion, important errors of metabolism can present as acute metabolic emergencies resulting in significant morbidity, progressive neurological injury or death. Maintaining a high index of suspicion of metabolic disease in an ill neonate is essential, as many disorders are treatable and most cases successful outcome is dependent on rapid diagnosis. And the take-home message that successful emergency management for inborn errors of metabolism achieved by promotion of anabolism, adequate energy in the supply, pharmacological or extracorporeal detoxification. Take-home message: don't miss a treatable disorder, don't miss a life-saving treatment. Thank you and sorry for the delay.
شكرا يا دكتورة علا.
I tried my best to squeeze but I cannot.
هي المحاضرة في منتهى الجمال.
I cannot يعني I tried.
موضوع مهم جدا 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 ويمكن لسه